This video explains all about bowel care. I am joined here by my colleague Paula to explain what you need to know.
How the bowel works. Normal bowel movements vary a lot. Some people have bowel movements every day and others may only have them a few times a week. In general, a bowel movement or stool should happen with little effort or urgency and without the use of laxatives. The digestive system. In order to understand how the bowel works, it's important to understand the digestive system. The digestive system is a series of hollow organs joined in a long twisting tube from the mouth to the anus. Digestion is important for breaking down food into nutrients, which your body uses for energy growth and cell repair. After a spinal cord injury, digestion continues, but the ability to control bowel movements may be affected. Food is full of nutrients which give us energy and keeps us well. When we eat food, it moves into the stomach to be digested. Then it moves into the small intestine, which draws out the nutrients into the bloodstream to be carried to the rest of the body. Digested food, not absorbed by the small intestine, moves into the large intestine. The main function of the large intestine is to absorb water and remove waste from the body. Waste is stored until it moves into the rectum and is expelled as a bowel motion. The rectum alerts the brain when it's full. The brain then sends messages to the bowel muscles to empty the bowel. How does spinal cord injury affect the way my bowel works? After a spinal cord injury, the type of bowel function you have will depend on the type, complete or incomplete, and the level of your injury. You will have either a reflexic, areflexic bowel, or mixed bowel, any of which can be referred to as a neurogenic bowel. If your injury is at or above the 12th thoracic vertebrae level, you will probably have a reflexic bowel. The sensation of needing to empty your bowel will not reach the brain, but it will reach the spinal cord. A sensory signal sent from the bowel travels to the spinal cord. The signal then loops back down along the nerves to the bowel muscles. The signal passes along a pathway called a reflex arc. To stimulate the bowel to empty, you will trigger this reflex by inserting suppositories and/or digital stimulation. Areflexic bowel. If your injury is at or below the first lumbar vertebrae, you will probably not have a reflex action and bowel movement. This is because the rectal nerves at the end of the spinal cord are damaged, so they cannot loop around to cause a reflex response, and the bowel muscles do not squeeze and cause bowel movements. In cauda equina syndrome, you may have an areflexic bowel. Manual removal of stool may be needed to assist the bowel to empty. Mixed bowel. If your injury is between T12 and L2, you may have a mix of reflexic and areflexic bowel function. Your medical and nursing team will help you work out which method of bowel management is best for you to use. What is a bowel program? A bowel program means finding a way to manage your bowel that works best for your type of injury or illness. As the bowel is not functioning the way it did before your spinal cord injury or illness, it needs to be retrained to work in a different way to achieve continence. An individualised bowel management program helps to maintain a good quality of life. The aim of a bowel program is to avoid constipation and to achieve regular and predictable emptying of the bowel at a socially accepted time and place, completed within a reasonable time, generally within 1 hour. Learning to manage your bowel care can be challenging. Bowel management is usually a very private function, and it can be difficult at first to discuss it with healthcare professionals. Our main aim is to help you to establish an effective and regular routine that will prevent or minimise accidents and complications. It may take some time and some trial and error before you establish a bowel program which suits you and your lifestyle. You will be supported during your rehabilitation to establish a bowel program that is suitable for you. Goals of a bowel program: to establish regular bowel opening, to complete a bowel movement within a 1 hour period, to minimise or eliminate unplanned bowel movements, to improve confidence in work and social situations, to help avoid complications such as constipation and diarrhea. Factors that affect bowel care. Bowel care is affected by many factors including illness, diet, exercise, medication, mobility, positioning, and fluid intake. Dietary tips. Dietary fibre. Dietary fibre, also known as roughage, plays an important part in bowel management. Fibre is found in whole grain cereal foods, porridge, wholemeal bread, or brown rice. fruits and vegetables. These foods are important for health and should be part of a healthy diet. Changing the amount or type of fibre in your diet may be needed to help you manage your bowel. There are 2 types of fibre, and each plays a different role in bowel management. Insoluble fibre passes through the digestive system intact. It helps you to pass waste more easily by making the stools bulky. This helps to prevent constipation. It is found in fruit skins, fibrous vegetables such as carrots and broccoli, wholemeal and whole grain flour, breads, bran and cereals. Soluble fibre dissolves in water and forms a gel in the gut. It helps to keep stools soft, making them easier to pass, which may help prevent or treat constipation. It is found in oats, rye, beans, peas, lentils, and the fleshy part of fruits and vegetables. Depending on your bowel type, you may need more or less fibre. Tips to increase fibre in your diet. Choose wholemeal bread. Choose high fibre cereals such as porridge, Weetabix, all bran. Aim to eat at least 5 portions of fruit and vegetables daily. Tips to decrease fibre in your diet. Use white bread. Use lower fibre breakfast cereals such as cornflakes or Rice Krispies. Try to have 5 portions of fruit and vegetables daily. This will provide useful vitamins. The importance of fluid. It's recommended that you drink approximately 1.5 to 2 litres of fluid, 8 to 10 glasses daily, in order to prevent constipation. Increasing dietary fibre without drinking enough fluid can cause hard stool. It's important to introduce fibre gradually. Drinking enough fluid will help to reduce the common side effects of increasing fibre too quickly, such as bloating and wind. Stimulant food and drink. Some foods called stimulant food or drink, such as alcohol, caffeine in tea, coffee, cola, and chocolate, prunes and figs, pure fruit juice, and the sweetener sorbitol may overstimulate the digestive system and draw excess water into the gut. Consider reducing these types of foods and drinks if diarrhea is a problem. Medication. You may be prescribed laxatives to help manage your bowels. There are many different types of laxatives which work in different ways. Laxatives come in the form of suppositories, tablets, liquids, and enemas. Some laxatives help stimulate the bowel and move the bowel motion into the rectum. Others help soften the stool to make it easier to empty the bowel. Suppositories are used for people with a reflexic bowel to help with emptying. Very occasionally, Microlax microenemas are used for some patients. Combination of laxatives are usually tried to see which ones suit your bowel regime best. See the table for examples. Bowel management after discharge. During your admission, your bowel will be assessed to determine the exact type of neurogenic bowel you have as a result of your injury. You will receive education from the staff nurses and healthcare assistants on the management of your bowel. The aim is to have a well-established bowel programme before your discharge, a programme that you can either manage independently or guide a healthcare professional or carer to perform for you. Public health nurses or a healthcare provider can assist patients at home who are not independent with bowel care management. This is generally arranged prior to discharge. Training in bowel care management can also be provided to a family member and a carer if required. Alternative methods of bowel management. If a regular bowel programme doesn't work for you, if you're having accidents several times per week, or it is taking too long to do your bowel care, you might want to consider transanal irrigation. This involves washing a quantity of warm water into the lower end of the bowel to wash out the bowel motion. The disadvantages of this method are: 1. The risk of trauma or perforation to your bowel. 2. There are certain conditions where you cannot do this. For example, if you have bad hemorrhoids. 3. There will be a cost if you do not have a GMS medical card. Finally, it's important to note that you will probably still need to take laxatives and eat a healthy diet to ensure that the bowel motion has advanced far enough into the rectum to enable you to wash it out. Finally, if you have tried both regular bowel care and transanal irrigation and neither work for you, you might want to consider referral to a surgeon for a colostomy. This might make life easier, but it is not a decision to be taken lightly, as it involves surgery, and we do not know the long-term impact, particularly for younger people who have a colostomy. If you are considering this, you should discuss it more with your rehabilitation doctor. Common terms. Abdominal massage. Pressure is applied intermittently to the abdomen in a clockwise direction along the usual lie of the large intestine, using the back or heel of your hand. Pressure is applied and released firmly but gently in a continuous motion around the abdomen, as instructed by your healthcare provider. Bowel care program. A planned intervention designed to ensure the regular evacuation of stool from the bowel. Bristol stool scale. This refers to a scale, see diagram, that healthcare professionals use that describes the consistency of your bowel results. Cauda equina. This refers to the group of nerves that emerge from the end of your spinal cord and activate the bladder, bowel, and sexual organs and lower limbs. This group of nerves are often referred to as the horse's tail. Cauda equina syndrome, CES, is the term used to describe damage to the cauda equina. This can affect bowel, bladder, and sexual function, as well as sometimes causing weakness of the lower limbs. It can have a number of causes, including a disc prolapse or a fracture of one of the lumbar vertebrae. Colostomy refers to a surgical procedure which diverts part of the colon through an opening into the stomach. The opening is called a stoma. A stoma bag can be placed over the stoma to collect the stool. A colostomy can be permanent or temporary. This option will be discussed if it is appropriate for your bowel care program. Conus medullaris refers to the tapered lower end of the spinal cord. It occurs around the level of the first lumbar vertebrae, L1. Conus medullaris syndrome is the term used to describe damage to the conus medullaris. This can also affect bowel, bladder, and sexual function. However, it's different to cauda equina syndrome, as you're less likely to have an areflexic bladder or bowel. It's equally likely to be reflexic or mixed. Constipation is generally described as having fewer than 3 bowel movements a week or infrequent bowel movements that are difficult to evacuate. Chronic constipation. Bowel is blocked by hard, impacted feces, but some liquids may manage to seep past the blockage. This condition is called overflow diarrhea. Diarrhea is passing loose or watery bowel movements 3 or more times a day, or more frequently than is normal for the individual. Digital rectal examination, DRE, refers to examination of the rectum by inserting a gloved, lubricated finger into the rectum. Digital removal of feces, DRF, refers to manual removal of stool from the rectum using a gloved, lubricated finger. Digital rectal stimulation, DRS. DRS involves the insertion of a gloved, lubricated finger into the rectum, followed by gentle, circular movement of the finger for at least 10 seconds to stimulate reflex evacuation of stool from the bowel. Gastrocolic reflex. This refers to a reflex response to the introduction of food or drink into the stomach, resulting in an increase in muscular activity throughout the gut. This may result in movement of stool into the rectum in preparation for evacuation. Patients are advised to make use of this reflex by eating or drinking 20 to 30 minutes prior to their bowel care program. It is thought that this response is strongest following breakfast. Neurogenic bowel. The term used to describe the bowel following nerve damage to the spinal cord or brain. Neurogenic bowel dysfunction may be reflexic, areflexic, or mixed. Transanal irrigation refers to a specialised irrigation system designed to assist the evacuation of stool from the bowel by introducing water into the rectum. This can be demonstrated and trialled where appropriate. Frequently asked questions, FAQs, about bowel care after spinal cord injury. Who supplies me with my suppositories, bowel medications, and bowel care equipment on discharge? What happens if I do not have a medical card? Your suppositories and medications will be included in your monthly prescription supplied by your local pharmacist. Your public health nurse, PHN, supplies you with gloves and incontinence wear. If you do not have a medical card, there is a charge for these suppositories, medications, and equipment. There is a hardship scheme that may be available to you, which can be facilitated through your GP or local pharmacist. Forms are available online at www.hse.ie or at your local health centre. How long will it take me to have a bowel motion following insertion of suppositories? Suppositories usually work within 15 to 30 minutes. Follow the manufacturer's guidelines. How can I manage bowel care abroad? If you require assistance to complete your bowel programme abroad, there is a limited EU agreement to provide care. Information can be sought through your local health centre or community health organisation, CHO area manager. Family members can be trained in bowel care while you're an inpatient in the NRH if requested. How do I manage a bowel accident? This may be a challenging and often embarrassing situation. An individualised, regular bowel programme will reduce your risk of accidents. However, illness, dietary changes and certain medications may affect your bowel care programme. You will learn to recognise individual triggers that may lead to bowel accidents. If bowel accidents become a frequent event, it may be helpful to discuss the problem further with your GP, public health nurse, with the spinal cord injury liaison nurse or your rehabilitation doctor. Can I change from a daily programme to an alternate day programme? The best programme is generally well established before you discharge from the NRH. However, you can liaise with the spinal cord injury liaison nurse after discharge regarding possible changes to your specific programme. What are the advantages and disadvantages of a bowel programme over a colostomy bag? This should be discussed with your spinal cord injury rehabilitation consultant and team to determine your suitability for this procedure. It may be beneficial to talk with other spinal cord injured patients who have had the procedure. Can I insert suppositories in the bed and then transfer onto the shower chair for toileting? Yes, you may insert your suppositories in the bed and then transfer onto your shower chair. Some individuals choose to wear incontinence wear during the transfer. Can the way my bowel works change over time? Yes, it can. In fact, the way the bowel works changes with age for everybody. For example, it's common over time for a bowel programme to take longer, and this can lead to constipation. It's important that you make adjustments to your bowel programme. For example, a change of medication when needed. Changes to your bowel programme can be discussed with your healthcare provider. Thank you for your time, and I hope you find this information useful.